So good day everyone, and my name for those of you who are not familiar with me is Tyrannosaurusvex, Tvex for short, and I'm actually here to give you some tips and tricks and general education on neuromuscular monitoring. So before we get into it, let's do some definition, shall we? So first up is the TOF count, which is the number of detected muscle responses when four supramaximal stimuli are generated at 0.5-second intervals to cause muscle contraction. The train of 4 ratio is the ratio of the fourth muscle response to the first one. Now you might be wondering, why exactly neuromuscular monitoring necessary? Why is it necessary? Well, because residual neuromuscular blockade could predispose to pork. Alright, sorry. A little typo. Clearly, nobody is doing any spell checks anymore, and here we go, and we fixed it. Alright, so residual neuromuscular blockade could actually predispose to post-operative respiratory complications, and this would be upper airway obstruction, reduced pharyngeal muscle coordination, increased risk of aspiration, and impaired hypoxic ventilatory drive. So how exactly could we decrease the risk of residual neuromuscular blockade? Well, first of all, we could use short and intermediate acting neuromuscular blockers, use quantitative neuromuscular monitoring, appropriate timing and dose of reversal agents, and perform endotracheal extubation only when the TOFR more than 0.9 is achieved. So let's go back way back in the olden days. Traditionally, clinical signs were used to detect the return of neuromuscular function. These would be sustained eye opening, which is unreliable, protrusion of the tongue, again unreliable, arm lift to the opposite shoulder, normal tidal volume, normal or near normal vital capacity, minimal respiratory pressure, all unreliable. But then came qualitative peripheral nerve stimulation, but this was also inaccurate because fade could actually still be present with the 2FR less than 0.9 and is difficult to actually detect it with the human eye. So, what's the new way? The right way? Alright, so let's get into it. Quantitative neuromuscular monitoring is the only way to reliably confirm recovery from neuromuscular blockade. It's recommended to perform extubation when the TOFR is more than 0.9. Now, there are many types available, some of which being electromyography, accelerometry, to name a few. And the site that we use is the ulnar nerve. The skin preparation is simple. You place electrodes on a clean surface, and if needed, you shave the area and then you clean the arm with an alcohol prep pad and you allow it to dry before application. And electrode placement, the anode, which is the black wire, placed on the ulnar nerve distally. The cathode, the red wire, is placed 1 to 2 centimeters proximal to this. Transducer placement, well, it must be placed on the thumb, ensuring that the thumb is actually free, because environmental movements could actually affect the accuracy of readings. Now, when you calibrate in the monitor, it actually improves the accuracy of the result, and therefore it should actually be done before the administration of any neuromuscular blocker. So remember to attach your monitor to the patient before the induction of anesthesia. Treat it as you would any standard monitor. And when you're administering the induction agent, you could go ahead and select calibrate on your machine, and you can assign a start to your ADA. And just between me and you, if you don't remember the step, reset the monitor and select supramaximal stimulus, which is 60 milliamps. So just a quick recap: attach the electrodes, induce the patient, administer your neuromuscular blocking agents, and calibrate. You monitor the depth of anesthesia intraoperatively and prior to reversal, and document the TOFR prior to extubation. So when exactly do we reverse neuromuscular paralysis? Well, we do this at the point where the procedure where the paralysis is no longer necessary. Remember, you do actually have to wait until skin closure to reverse paralysis. And a TOF count of at least 2 should be achieved before actually administering the reversal agent. But if possible, wait until 4. The approximate time from administration of the reversal agent to TOFR of more than 0.9 is 10 minutes. So keep this in mind when you're actually doing the timing. And with respect to this, I feel you could read this in all your own time. This too, I get from reliable sources that it's actually going to be printed and available on your anesthetic machines. So some final tips, alright? Be patient. Unlearning behaviors is always difficult. Patient safety always over turnover time. Always isolate the hand being used for monitoring. Aim to obtain 2 consecutive values before actually acting upon it, because external environmental factors could actually impact upon the monitor. And well, thanks for watching. And make sure and use your monitor. Otherwise, it's me and you. Okay, bye!